Welcome to our Digital Infoday Session. In this event, we will talk about why and how myeloma can affect the kidney. We will be discussing what the kidneys do, how myeloma affects the kidney, and we will also look at the treatment and management of kidney-related problems. The event is being recorded and will be available on Facebook and on our website shortly after. If you would like, the structure of the webinar will be a presentation from our speaker and then some question and answer session at the end. The event is being recorded and will be available to watch on our Facebook page. If you would like to submit questions during the event, please use the question and answer box. If you would like to speak with each other, you can use the chat option. We'll also be posting useful links in this throughout the event. Both can be found at the bottom of your screen. If you have a question and perhaps would rather not ask it this evening, or you think of one after the webinar is finished, you can always talk to your hematology team or get in touch with us via the Myeloma info line or the Ask the Nurse service. I'm Caroline. I work in science communication at Myeloma UK. And some of you may not be familiar with Myeloma UK. So before we start, I'd like to tell you briefly who we are and what we do. Myeloma UK exists to support all those affected by myeloma and its related conditions, which include smoldering myeloma, MGUS, and AL amyloidosis. We are patient-focused and we aim to empower, inform, and support patients in everything that we do. As an organisation, we rely on the generosity and kindness of supporters, fundraising and donating. Myeloma UK receives no core government funding, so your support is vital, and we're truly thankful for all your contributions, as they allow us to continue working to help patients, their families and friends. For our webinar today, I'd like to welcome this evening's expert, Professor Paul Cockwell. He's a consultant nephrologist, Professor of Nephrology and President of the UK Kidney Association, University Hospital, Birmingham. Paul, I'm going to hand it over to you to start today's webinar and take us through the presentation.
Thanks very much, Caroline, and good evening, everybody, and welcome. It's great that we've got so many people join this evening, and many thanks indeed to Myeloma UK for asking me to lead this presentation this evening, and also to deal with some questions. And we've already seen a number of questions come through, and I'm sure there'll be questions that will come to your mind as we go through what I'm going to talk to you about over the next 30 to 40 minutes or so. I'm going to start by trying to give you a picture of what the kidneys do, because if you've got kidney problems, whether it be with myeloma or any other given condition, it's really important to have an understanding of what the kidneys do and why they can cause problems in some settings. I'm going to also then move on and talk a little about how the kidneys can be affected in myeloma. There's a lot of misnomers about the kidneys in myeloma, and it's actually only a relatively small proportion of people with myeloma who get bad kidney failure. That most kidney problems with myeloma come and go. And indeed, most kidney problems that people with myeloma get are not directly related to the myeloma itself. It's because people are unwell in other ways. For example, people are dehydrated or have an infection, or may have had some tablets that can interfere with the kidney function. And that is very common generally. There are a lot of people who come into hospital unwell who have an acute drop in their kidney function, something we call acute kidney injury. And that occurs with any number of different causes. And people who've got myeloma are as susceptible as people who are sick from other causes from that. And then within that, there are a relatively small proportion of people whether myeloma itself is causing problems that can lead on such that people can get complete kidney failure. And we'll talk a little bit about that. We'll then talk about how this can be managed and treated. And what I'm going to try and do is hopefully give you a language that you can use with your clinicians so that you can baseline your kidney function and also be able to talk to your medical team as to whether there are any particular risks for you as far as the kidneys are concerned. So we'll spend a little bit of time going through these different areas. I will explore one or two other things, and hopefully you'll learn a little bit about the kidneys generally, and hopefully I'll be able to allay any particular concerns that you've got, because quite often we look at risk when we have a medical problem, and that risk is quite difficult to gauge. And I'm aware that often when you're talking to healthcare professionals, they're talking about your kidneys being at risk. And what you really want to know is, what does that actually mean, and how do I know what the risk for me is? And hopefully I can give you some pointers around that, that if you do have myeloma or you're with somebody with myeloma, that you have a language that will allow you to know whether or not you're at particular risk of running into kidney problems, or if you've got kidney problems, then are there specific things that are important for you to know and understand or see as happening during your future? So if we go on and look at the next slide. So the simplest way of thinking of the kidneys is as the body's waste disposal units. And I'm sure the large majority of you who are on this webinar will have an understanding of what the kidneys do. But if you go out into the general population, many people don't know what the kidneys do and often get them confused with the liver or other vital organs. And the best way of thinking about the kidneys is to see the kidneys as a filter system that's taking the waste that your body produces directly out of the bloodstream and dropping it into the urine. And if you don't have kidney function, what happens is that waste accumulates. And pretty quickly, if you've lost all your kidney function, it makes you unwell. And without treatment, if you get complete kidney failure, people will usually die within around 7 to 10 days of having complete kidney failure. Next slide, please. So just hold that picture of those disposal units in your head, and then think a little bit about how the kidneys actually work as disposal units. So if you take your hands and just put them round your flanks, just in the upper abdomen, and press, your kidneys are about 4 to 5 centimeters under your fingers. So they're in your back and they sit on the muscles that go down and effectively able to lift your legs up and down. So that's where the kidneys sit. They're quite complicated organs because they've developed in a way where they work in as filters, but those filters are then disposing of urine by draining through long tubes down into your bladder, and then you pee and you pass out waste products. If you look at the kidney itself right up close, on the right-hand side here, what you've got is the core filtration unit of the kidney. So you see on the right-hand side that little bundle of blood vessels on the top right called the glomerulus. That's the filter unit within the kidneys themselves. And you've got 1 million of those glomeruluses, or glomeruli as we call them, in each of the kidneys. And it's those glomeruli which have blood moving through them at very high pressure. And then urine is forced out of the blood as blood goes through the glomeruli, and then comes together to drain out of the kidneys and into the bladder. And in that action of drainage and filtration, the kidneys become very vulnerable because they are so sophisticated when people get sick of any given cause. So kidney failure is very common in people who are sick, as I've already said, of any particular cause, but also really common as people get older. So by the time you get to the age of 70, around 1 in 5 people have significant, what we call chronic kidney disease. That is, kidneys that are not working normally. So one starting point for you all to think about is, what actually is your baseline kidney function? Are you somebody whose kidneys are working normally, or are you somebody whose kidneys are not working normally as baseline? If you have myeloma, did you have kidney problems before you developed myeloma itself? And it's important to know that quite a lot of people have pre-existing lower kidney function before they develop any other illness that can take the kidney function down. The good news is the kidneys have got a lot of reserve, so that you can lose about 80 to 90% of normal kidney function and still have enough kidney function to keep going with. So that inbuilt reserve is what protects us from running into big problems when we get sick. And even when you lose a lot of kidney function, you usually do not need to have replacement of kidney function through treatment like dialysis. So next slide, please. So the kidneys, as a top line, have that job of removing waste from the bloodstream. There's one other thing that I want you to think about what the kidneys do. Forget about the more esoteric things like producing hormones, but just focus on the importance of the kidneys for keeping the water content of the body constant. Now, in myeloma, there's some interesting things can happen with the kidneys, particularly when people present with myeloma and kidney problems. Quite often, people with myeloma can get dehydrated quite quickly because the protein produced in myeloma that can cause kidney damage acts as an encourager of urine output coming out of the kidneys. It's what's called an osmotic protein. It pulls out urine so people can get dry, which is one of the reasons why you're encouraged when you have active myeloma, particularly if the protein that interferes with the kidney function, the light chains, are at a high level to keep a good amount of water going in to ensure that you're flushing the kidneys out and that you're not at risk of becoming dehydrated. In addition, the kidneys keep a number of other things stable. And sometimes you'll hear people talk about we need to check your potassium levels. So if you look at the electrolytes that the kidneys regulate, the potassium is the one that's the most important in terms of putting people at immediate risk. So if you get high potassium levels, it can be toxic to the heart. So when I'm working as a kidney specialist, I'm not so interested in what the overall kidney function is. I'm more interested in what's going to happen in this period of time if you've got a high potassium level, if you're sick. So when you have blood tests done, that's one of the things that's being checked out, particularly when you're unwell and you're in hospital being managed for a complication of your myeloma or myeloma itself. So next slide, please. So putting all that together as background, how common then is myeloma kidney disease? Now, you've got to be careful with the terminology that's used. And as you know, healthcare professionals can be very loose in the way that they use words. Most people who have kidney disease when they present with myeloma do not have myeloma kidney disease per se. They don't have the myeloma directly interfering with the kidney function. What's happened is that somebody with myeloma has become unwell with an infection or dehydrated, and with that, they've lost their kidney function. And so up to about 1 in 5 people when they originally present to hospital are diagnosed with having myeloma through being seen to have kidney problems at presentation. And some of you with myeloma who are on this particular webinar will have come to the attention of healthcare professionals that way. You may have been unwell, you may have started to vomit, you may have had some bone pain, you may have had an infection. You've seen a healthcare professional, often in hospital because you've gone to an emergency department, you've had a blood test done, and you've got low kidney function on the blood test as part of the combination of problems that you've got. So that's a presentation. Around 50% of people in total, though, irrespective of how you present with myeloma, will have low kidney function at diagnosis. Now, when we've looked at what happens to those individuals, the majority of them go back to normal kidney function. When the myeloma is treated and when the complications associated with the myeloma is treated. But for 1 in 30 or so people, there's genuine myeloma kidney disease, where an individual gets severe kidney damage such that at presentation, they either need or are at risk of needing dialysis treatment. Now, these numbers have changed quite a bit over the last decade or so. So if you go back 10 or 15 years, and often the textbooks and the literature that you read take a while to pick up, to pick up changes in the incidence of things happening medically, people will be quoting 10% of people will get kidney damage of sufficient severity to require dialysis. In fact, around 10% of people have severe kidney failure when they present, but the large majority of those, or the majority of those, don't actually need dialysis, because once you start treating, the kidneys get better. But some of those individuals will have severe kidney failure and need dialysis treatment. And dialysis is artificial kidney treatment where the individual who's affected goes onto a machine that holds within the machine a filter. So blood is taken out of the body, usually through a line, which is put into a blood vessel in the neck, passed through a pump through a filter and returned. And in that filtration, those waste products that the kidneys are no longer removing are being removed. So about 1 in 30 people currently develop kidney failure of sufficient severity to need dialysis. Now, this usually when it happens will happen when you present with myeloma. It's far more common to have severe kidney damage, what we call severe acute kidney injury, at the first presentation than to subsequently develop it as you have treatment and go through a long period of time with myeloma. Because if myeloma returns or relapses, yes, it can cause kidney damage, but usually that's been picked up because your specialist is monitoring you, and therefore your treatment for myeloma when you relapse is usually not as advanced in terms of its risk to the kidneys as when you present. That's a really important point, because people often, when they come out of their initial illness with myeloma, will have a lot of concern that their kidneys will be at the same level of long-term increased risk. Whereas what we know is that's not necessarily the case. Does that make sense, Caroline? I can see Caroline on the screen and she's going to tell me if I'm not explaining things properly. So I want you just to bear that fact in mind as we go through myeloma kidney disease, or myeloma cas nephropathy, as it's called, in a little bit more detail over the next 10 minutes or so. So next slide, please. Okay, so I'm reinforcing what I've said here, is that severe kidney disease, most common when people present initially diagnosed with myeloma, and that individuals with no myeloma are less likely to get severe kidney disease because the hematology team are monitoring and would usually treat before there's risk of severe kidney disease. So when you have your blood test done, you will always have your kidney function checked. And often people don't ask what they're having done when they're having blood tests done. Healthcare professionals should be explaining, because every time you have an invasive test, such as a blood test, our job is to explain to you why you're having that test. But when you're having that test, you will almost always be having your kidney function done. Kidney function monitoring is one of the commonest of all blood tests that's done in day-to-day care of people, irrespective of what underlying condition they have. So your kidney function will be monitored, often at the same time as your myeloma is monitored, where you have your serum protein electrophoresis and serum free light chain levels checked to see what level of activity the myeloma is at. So next slide, please. Okay, so just to come back to this cause then of kidney disease in myeloma, what I've told you is the large majority of kidney disease is caused by things that are not specifically caused by myeloma interfering directly with kidney function. I've shown you that on the left-hand side here. People get dry, they may have some Voltarol or Brufen for bone pain, for example, or muscle pain. Those medications themselves can interfere with kidney function. A high calcium level, it doesn't matter what the cause is, whether it's myeloma or any other cause, there's lots of causes, can stun the kidneys and cause the kidneys not to work as well. And then infection, we know that people with myeloma are at increased risk of infection. Again, when you've got an infection, the kidneys are at risk of having an acute drop in their function. So that's the majority of causes. The causes on the right-hand side are very rare causes. It's very rare for the myeloma treatment itself to cause kidney failure. There's a few case reports of some idiosyncratic odd reactions within the kidneys to myeloma treatment. The bisphosphonate treatments that you're given to, if you've got myeloma, to get the calcium under control and to treat the disease itself, they're actually very rare or pretty rare as causes of kidney disease. But in some individuals with more advanced kidney disease, we tend not to use those as chronic treatments, but we have alternative treatments to those. And very rarely, and this doesn't just apply to myeloma, it applies to anybody who gets a course of antibiotics, we see some antibiotics can sometimes cause the kidneys to suddenly go down in their function. But those on the right-hand side are rare disease. In the middle then, you've got the main cause of severe acute kidney injury, those individual patients who get bad kidney failure, where the kidneys are at a level at which the individual may need to have replacement of kidney function with dialysis. And that directly relates to the free light chains, which are produced as a consequence of the myeloma. So when you talk to your specialists, ask them what type of myeloma you've got. You'll have done this anyway. You may have an IgG kappa myeloma or an IgA lambda myeloma. There are 5 of the Ig types, but then there are only 2 of the light chain types in the immunoglobulin. One of those types is kappa, and one of those types is lambda. So have you got a kappa myeloma or a lambda myeloma? Now, in half of all cases of people who get really bad kidney failure with myeloma, the individual has what's called a light chain only myeloma. That is, you can't detect a whole immunoglobulin myeloma in the bloodstream, but you can detect a light chain, either the kappa or the lambda. And the reason those molecules cause kidney trouble is because they get stuck in the filter, which is the kidneys. And that's why people who've got myeloma, who've got very high levels of either kappa or lambda, are at risk of having myeloma kidney failure, or the healthcare professionals will call it now myeloma cast nephropathy. And I may have a slide or two to show you of what that looks like in a moment. So next slide, please. Okay, and this reinforces, so this really reinforces what I've just said on the next slide, but it's worthwhile going through this. Now, many of you know this anyway. If you don't, it's really important, I think, as a healthcare professional, for you to have enough understanding of your disorder, for you to understand why certain things can happen when you have myeloma or you have a related disorder. So what you've got here with these cells, these are plasma cells, okay? And you'll know that myeloma is a cancer of plasma cells. Each plasma cell produces an immunoglobulin, and the bigger molecules outside the cell, that's the intact immunoglobulin molecule. The intact molecule consists of chains, heavy chains and light chains. And when you produce an intact immunoglobulin molecule, you produce also from the plasma cell the light chain in excess. And that happens in a normal situation. So if you take blood from somebody who hasn't got myeloma, you'll find the intact immunoglobulins, which are normal, but you'll also be able to measure these light chains, either a kappa or a lambda, at low levels in the blood. When you have myeloma, that abnormal intact immunoglobulin that you're producing from a plasma cell cancer, which is produced in excess, is also producing an excess of the light chains, either kappa or lambda. You don't get both, you get one or the other. So speak to your healthcare team and say, have I got a kappa or have I got a lambda myeloma? Because what your healthcare team will be doing is they'll be monitoring the levels of the kappa and lambda in your bloodstream. So one of the ways in which you can assess the activity of myeloma is to measure what's called serum-free light chains, to measure the kappa level or measure the lambda level. And that for you is a really important figure because it's the level in the bloodstream that indicates what the risk to your kidneys are. You actually need a lot of kappa or lambda in your blood before your kidneys start to get into a risk territory. And by a lot, I mean several grams per litre of blood. The starting level at which people can get these proteins, these light chains interfering with the kidney function, is 500 milligrams per litre, about 500 milligrams per litre, or half a gram per litre. So if you're talking to your specialist, say, what are my light chain levels? And if they say 100 milligrams, you're pretty safe. Once you're up above half a gram, most people will never develop kidney problems, but people start to get at increased risk of developing kidney problems, that sort of level. So think about the intact immunoglobulin, think about the light chain. Now, if you remember about 10 minutes ago, I explained to you that the light chain, often in people who've got kidney failure secondary to the myeloma, that is the myeloma cas nephropathy, they have a light chain only myeloma. 50% of the time, people will have a light chain only myeloma when the kidneys stop working completely. That means that you can't find the intact immunoglobulin, but the myeloma shows itself by these very high light chain levels. Now, one question that's come through, and I'll preempt it, is can non-secretory multiple myeloma cause myeloma cas nephropathy? Which is a really smart question to ask. And the answer is in the title, isn't it? Non-secretory. There is no protein being produced that can be measured at a significant level within the bloodstream. So non-secretory multiple myeloma doesn't cause myeloma cas nephropathy because it's not secreting not only the intact immunoglobulin, but light chains to a level at which the kidneys get affected and stop working. So next slide, please. So remember when we showed you the slide early about those glomeruli, and there are 1 million of them in each kidney. Here's what happens when you've got these high levels of light chains in the bloodstream. So look at that bundle of blood vessels in the right, the glomerulus. And the light chain levels are high in the blood. And those light chains are small enough to get out of, be squeezed out of the filtration units, the glomeruli, into the urine. And when they squeezed out into the urine, the levels can get high enough so that those light chains precipitate out within the kidneys themselves and then block off the kidney function. And that precipitation we call cast formation. And I might have a slide on that actually. So next slide, please, Kirsten. Oh, actually, this just reinforces what I said a few minutes back about the levels of light chain levels which people get cas nephropathy. So 500 milligrams is the starting level, really, at which people start to run into potential risk. But look at this in the middle here. Most people who get severe kidney failure due to cas nephropathy have 5 grams per litre or more in their bloodstream, which is a really high level of any protein, and is several hundred times the normal level. That's one of the reasons why people don't tend to present on relapse with myeloma cas nephropathy, because your hematology doctors will never let your light chain levels get to that level without having treatment to get those levels down. So those thresholds are very important. So as I said earlier, try and get a steer from your healthcare team as to what your serum-free light chain level is. Next slide, please. So those very high light chain levels will filter out in the kidneys, and you get this. So when you take a biopsy from somebody, kidney biopsy, a fine needle into the kidney, look at it under the microscope in somebody who's got myeloma and CAS nephropathy, this is what you see. You see, this is very high magnification, but right in the middle, there should be nothing in there. That should just be a hole down which urine flows. But in this individual who gave permission for the biopsy and permission to go on and participate in a study which involved looking at kidney biopsies and understanding what was happening with them in myeloma, the kidneys being blocked because this cast of high levels of light chain has precipitated out within the kidneys. Next slide, please. And the problem with this particular medical combination is it's a real emergency for the individual that's affected, because what will happen is that if you don't treat it, pretty quickly the kidney gets so scarred that it will never start to work again. So what we have here is a kidney biopsy from somebody who's had CAS nephropathy on the left. So if you look on the top left, you can see some of those casts at a lower magnification in the left-hand panel. And that individual we treated really hard to try and get their myeloma under control, but we were unable to do so quickly enough for them to recover kidney function. And when they had a repeat kidney biopsy 6 weeks later, what you see on the right-hand side is a kidney that's scarred off such that it will not work again. And we looked at a series of individuals and really showed that it was so important to treat the myeloma very aggressively when people present with severe kidney failure, when the light chains have caused the kidney failure. Next slide, please. Okay, so that's the pathway that you need to think about when you think about the kidney involvement in myeloma, where most people with problems do not have myeloma CAS nephropathy. People who have myeloma CAS nephropathy are people who have severe kidney failure. Some of them need dialysis treatment. They will have very high light chain levels, and they need to be treated really quickly. Now, the other test, talk with your doctors about, if there are two tests you really want to know, is what's my kidney function, doctor? And the answer is that test to describe your kidney function is called an estimated glomerular filtration rate. Okay, so anything less than 60 is a low estimated glomerular filtration rate. When you have myeloma CAS nephropathy, the glomerular filtration rate is usually down to 50 or less. And people with a glomerular filtration rate of 10 or less are in the area where they need to have emergency dialysis treatment. People who've got a glomerular filtration rate of 20 ml per minute or more and have got myeloma, some specialists wouldn't tell you this, but I feel comfortable saying it, I'd be pretty relaxed. Your risk of kidney failure is actually low, and your risk of getting myeloma subsequently taking out the kidney function is also low. And we know that because we've followed people up over a long period of time when they've recovered kidney function after they've had myeloma, and they've recovered kidney function to a level which is lower than normal. And relatively few of those people ever go on and get kidney failure that requires dialysis treatment. And generally when they do that because the myeloma's relapsing in a way that's very challenging. One of the questions that's come in that we've been asked is, a lot of people with myeloma die of kidney failure. Is that correct? I'm paraphrasing there. No, it's incorrect. I mean, you don't die of kidney failure if you have dialysis treatment, if your kidney failure is treated. So kidney failure is only a cause of death in myeloma if the myeloma has relapsed and has become resistant to treatment, and individual affected, together with a healthcare professional, has taken a decision that they do not wish to receive dialysis treatment. And that does happen occasionally, but kidney failure itself is not a cause of death in people with myeloma. It's the myeloma relapsing and being resistant to third or fourth cycles of line chemotherapy, and kidney damage, kidney failure being part of that process, rather than a decision not to treat the kidney failure. So next slide, please. Okay, so, and this may be the most important slide in terms of what you can do if you get bad kidney failure when you have myeloma. You have to treat the myeloma. There's no point in treating, we'll give you some fluids, we'll get your calcium down. You have to treat the myeloma. So in my practice in Birmingham, I've been very fortunate because I've worked with hematology doctors over a long period of time, and we've done a series of studies which effectively treat people who've got myeloma and severe kidney failure as medical emergencies. So as people present, we really focus on making sure that people at presentation get high-dose steroids and they get chemotherapy as quickly as possible. So at presentation, first time people are diagnosed with myeloma, the standard of care internationally when you have kidney failure is bortezomib-based. So it's bortezomib, dexamethasone, and usually a third agent as well would be the current recommendations. If you relapse and get acute kidney injury, second-line treatments like Revlimid and others are also very effective at treating the myeloma and getting the light chain levels down quickly. It's the speed at which the light chain levels can come down is what protects the kidneys and allows them to recover their kidney function. Okay, so high-dose steroids when you have a relapse and severe acute kidney injury, or when you present, immediate high-dose steroids is important. And as soon as a diagnosis is confirmed, straight on to chemotherapy. And what does that mean? Well, ideally within 48 hours of having that diagnosis made, if you've got severe acute kidney injury. And in the significant majority of people, probably now about 2/3 of people will recover their kidney function and come off the dialysis treatment if they receive very quick treatment of myeloma. There are then other things, bring the calcium levels down. We've got ways of doing that. The fluid story with myeloma is interesting. So people say drink 3 liters a day. In fact, if you go back and look at the original studies asking how much fluid should people drink to protect them from myeloma affecting the kidneys, it's not about how much you drink, it's about how much urine you pass. And in fact, it's maintaining a urine output of in excess of 3 liters or more a day. So it's a lot of urine that people need to be passed. And to pass 3 liters or more, you probably need to have 3.5 to 4 liters of fluid in. In hospital, if people have got a urine output, we often put a drip up to get that going. What about when you're at home? What's the advice if you're otherwise okay and your myeloma is in remission? Well, yeah, drink reasonable volumes. Drink to thirst. Drink a glass of water every couple of hours or so, but don't obsess about it. Don't get to the stage where it dominates what you do. Just drink if you're thirsty, and just be careful that you don't become too dried out. Your risk actually is low unless the myeloma you have is relapsing and your light chain levels are climbing. Next slide, please. Okay. And there are some general comments, and I'm not going to go through this slide about treating and managing kidney disease because I don't want to get away from the core thing here, which is the main area we've got to focus on are people who are at highest risk because they've got very high light chain levels. It's important if you get symptoms generally that you get medical care rapidly. There's a lot of talk about what are the symptoms of kidney disease. The reality is most people don't have symptoms of kidney disease. And many of the symptoms that you can get with kidney disease are usually attributable to other things, such as an infection or such as a complication of the myeloma itself. So I don't want you to focus too much on thinking, oh, I've got to check out that I'm not getting breathless or swollen. My main message is if you have a symptom, irrespective of what that symptom is, because you have myeloma, you need to get that checked out quickly. You just look to get an early medical review because there may be one of a number of underlying causes of that. Usually those causes won't be significant or won't mean anything, but because if you have myeloma, a delay in making a diagnosis when the problems related to the myeloma can cause more trouble, it's important to get early medical attention. And that, of course, is why a lot of you will be in services where you have direct access to your healthcare professionals and you have telephone numbers that you could ring. And you should have a low threshold when you develop symptoms for taking advice around what those symptoms may mean for you and whether you need to be assessed and managed. So next slide, please. Okay. And then just some general comments, and I think we're probably going to finish on the slides themselves and move over to questions in a moment. But just some general comments, and some of these may come up in questions anyway. So the good news with myeloma treatments is that the novel chemotherapy treatments that are now being used, there's been incredible developments over the last decade, can be used in people with kidney failure, including people with severe kidney failure needing dialysis. There are dose adjustments of some of those medications, firstly. Secondly, stem cell transplants. There'll be people on the webinar who've had autologous stem cell transplants, often more than one. They can be used in people with kidney failure, including people requiring dialysis treatment. This question of kidney transplantation, what happens if you get kidney failure with myeloma and you're on dialysis and you've not recovered kidney function? Can you have a kidney transplant? I think we're at a tipping point in this now, so that the outcomes with myeloma have improved sufficiently that it does become a serious consideration for people who've got myeloma that's either in a complete or a very good partial remission. And certainly in the UK, we're looking at the guidelines in this area at the moment. Historically, people with myeloma haven't been considered for a kidney transplant because the benefits of having a transplant are outweighed by the risks of an early relapse with a myeloma, meaning the intensity of a treatment for a kidney transplant and taking that additional healthcare burden up front was probably historically has not been of sufficient benefit. And the guidelines say no, but we're now looking at that and reconsidering that. And it really has been astonishing of how dramatically outcomes have improved, probably over the last 15 years, actually. Next slide, please. Okay, and I've already told you this, and you can read it. So 1 in 30 people with severe myeloma or myeloma and severe acute kidney injury need dialysis. And with rapid early treatment, 2 out of 3 of those individuals will recover. How do we know that? There have been 2 important, what we call randomized controlled trials done in the last 4 years, one in France, one that we did in the UK and Germany. They showed that about 2/3 of people with bortezomib-based chemotherapy regimens who need dialysis at presentation recover kidney function, and 1/3 of people remain on it long term. Historically, I look at my career as a kidney specialist, go back 15 to 20 years, it's turned around. 15 to 20 years or so ago, 90% of people would stay on dialysis once they presented requiring dialysis treatment. Next slide, please. Okay, and that's just a few comments on the specialist support available for you. So you may not see this, but your hematology team will be working with a local kidney specialist. And if there's any particular problems related to your kidneys, then the kidney specialist will be involved. If you come into hospital, you've got severe acute kidney problems, often you're under the care of the kidney specialist rather than the care of the hematologist, and the hematologist comes in and supports your care from a myeloma perspective. Next slide, please. Okay, and I've said most of this anyway in a different way during the presentation itself, because I think we should probably move on to some questions, Caroline. Thanks.
Yep, that's right. Thank you, Paul. That was a great presentation with lots of very interesting information that I think everybody will have found helpful who's watching this evening. So yeah, it's the question and answer session. So there's been a number of questions that have been pre-submitted. So if we start with one of the questions that actually we get quite often from patients, and you mentioned earlier in your presentation about the non-secretory myeloma and whether it causes kidney disease, but some patients ask, is there any specific type of myeloma that's more likely to cause myeloma kidney disease? And does your type of myeloma affect your risk in any way?
So light chain only myeloma is more commonly associated with severe acute, we call it severe acute kidney injury. So light chain only myeloma. So if you look at people who get the most severe kidney failure, then 1 in 2 people, or 50 in 100 people with the more severe kidney failure, have a light chain only myeloma. Whereas if you look at myeloma generally, I think only about it's 20% of people, 20 in 100, have light chain only myeloma. So the individuals whose myeloma, when you look for it in the bloodstream, is just seen through the presence of a very high light chain level, are at increased risk. It's difficult then to look at the studies that have been done and be specific to show any additional risk associated with any particular isotype of myeloma. Generally speaking, there's more kappa than lambda myeloma because kappa is a 2-to-1 ratio. If you look at the recent studies, certainly for the dialysis people who present requiring dialysis, it's more of a 50-50 split. So there may be something in there of a lambda isotype being at increased risk, but I'm a little bit hesitant about that because I don't think there are sufficient numbers there on a population basis for us to make too much of a call on it. I'll go back to what I said during the presentation itself. It's not so much about the type of myeloma you've got, it's about the level of light chains that you've got in the bloodstream. So it's those light chain levels that are the major determinant of whether or not the kidneys are at risk of failing. Everybody's unique in this. Everybody has their own level at which the kidneys will fail. So some people can have 1 gram of light chain and get a castaphropathy. Other people can have 20 grams and not get it. So each light chain is unique in the level at which it precipitates out and causes kidney damage. But the question I would ask your healthcare professional, if there's 2 measurements you want to know, it's what, in terms of your kidney health in respect of myeloma, it's what's my eGFR, so what's my baseline kidney function, please, and what's my light chain level, and is that changing? Is it going up with time, and is it going up to a level at which there may be a risk to the kidneys? I'll go back and say it again. It's unusual to get kidney failure secondary to myeloma on relapse. So the biggest risk is for people who don't yet know they've got myeloma. It's at presentation.
And to kind of just expand on that a bit, so you're like what you're saying is that, so for patients so I think Jane had asked that question, that if you've not had renal or kidney problems at presentation, you're less likely to get it at relapse.
Yes,
but I'm guessing that some patients could have kidney problems at relapse because of not necessarily light chains, but from other factors related to their myeloma or the medication that they're taking.
That's correct. So when you have acute kidney injury, a drop in your kidney function from what it normally is, a sudden drop, is common. It's common in people with myeloma. It's common in people who come into hospital with a pneumonia or having bled from their gut or with a stroke or with a heart attack. How common is it? So 1 in 7 people who are admitted to a hospital acutely unwell will have acute kidney injury. It's incredibly common because the kidneys are so sensitive to damage. So the large majority of people with myeloma will have that sort of acute kidney injury when the kidney function goes down. And that drop in kidney function usually improves, comes back when you get the right amount of fluids and infection is treated, and any other causes that could be contributed are treated. But it's those smaller proportion of individuals that have got very bad acute kidney injury, that is, the kidneys have stopped, so there's a risk of them needing emergency artificial kidney treatment, who have very high light chain levels, are the big at-risk group. So the big thing from a patient perspective, when if somebody says to you, your kidneys aren't working, the first question you want to ask is, are you sure I've not got myeloma cas nephropathy? Is this my myeloma interfering with my kidney function? And you really want the healthcare professionals to be able to tell you what your light chain levels are and tell you whether or not this is associated with your myeloma, because then it's a very different approach. Then you would want to be seen as having a medical emergency that needed very rapid evaluation and rapid introduction of chemotherapy that's going to sort out the myeloma, or at least bring the light chain levels down below a level at which they continue to cause trouble with the kidneys. So what's my kidney function? What's my light chain level? My kidneys have stopped, or they've stopped working as well as they were working. Could this be myeloma cas nephropathy? What's my light chain level now that I'm sick? The reason I'm emphasizing these points is that remember that myeloma itself is a relatively rare disease. Myeloma and severe acute kidney injury is rare in terms of how often it happens. It's not rare for you as a group because you've got myeloma and many of you will have had kidney problems. The healthcare professionals you're coming in touch with may not have seen it. They may not understand it. They wouldn't have had the bandwidth to take it in. And therefore, to get them focused on that specific question could really help you. You know, what you need is a kidney specialist or a hematologist involved in your care as quickly as possible. If you're admitted on an unselected acute medicine take, or with something and you're under a non-specialist clinician, it's important to get a specialist clinician involved as soon as possible. And you're very right to represent your corner on that, and call people out if they're not having the discussions with specialists who can advise. So there's a second answer that's part of that. So if you look at, I can tell you what happens 2 years. So I can tell you what happens in a 2-year period after somebody presents with myeloma and bad acute kidney injury requiring dialysis, because we did a study on this called ULIGHT, which was a UK-based study, German study, and we saw 2/3 of people get better. So 90 people came into the study. Over 60 people recovered their kidney function. And of those 60 people who recovered their kidney function such that they came off dialysis, only 3 people went back into bad kidney failure requiring dialysis over that 2-year period. And those 3 people, sadly, did that because their myeloma relapsed and was refractory to treatment. So they died of myeloma. They didn't die of kidney failure. So the relapse in itself was an event which showed that the underlying disease had got to the stage where it had taken over. Now, I'm being careful here in how I use my words, because I don't want you as an audience to go from A to Z and say, oh, that's a catastrophe. What if that happens to me? Because firstly, I'm not a blood specialist, I'm a kidney specialist. And secondly, I'm astonished by the rapid development in treatments that are available. And even that study, which was done between 2000 and, when did we start that? We started in 2008, took a long time to recruit into, we finished recruiting around 2014, it was all Velcade based. Even that study is now historical with the developments in treatments.
That's perfect. We've just had a live question in. So Steve was asking about calcium levels. So earlier in your presentation, you talked about how bringing down the calcium levels can help. But actually, some patients are on calcium tablets. Is that something they should worry about, or?
That's a really great question. The answer is that when you're in remission, you may well be calcium deficient, particularly if you've got some chronic kidney disease, because low calcium levels are common in chronic kidney disease for reasons that I'm not going to go into. And therefore, doctors will prescribe calcium supplementation. And some people may be having vitamin D supplementation as well. Low vitamin D levels are very common. That's fine. But just need to be aware of the fact that if you become unwell and you get a relapse, if you have any doubts at all, you need to come off the supplementation quite quickly, because your risk of the calcium level shooting up will be fairly high. In practice, that's common, but I have seen it happen. People have been on calcium supplementation for a year to 18 months, get a relapse of myeloma, and the calcium level will shoot up. As you know, high calcium levels are common in people who present with myeloma. Probably about 1 in 3 people who present with bad kidney failure with CAS nephropathy also have high calcium levels as well in presentation. It's usually straightforward to get those calcium levels down quite quickly. But yes, I mean, if you felt any calcium supplementation, that's okay. But need to be cautious about it if you get an intercurrent illness. It's back to what I said, is get an early medical review if you've any doubts at all that you're getting symptoms that are unexplained. There's a question on Brufen, Caroline, which
that's out. Yeah,
it's good to be
the next one.
And lisinopril as well, which is a really good question. Do you want me to take those?
So if you want to start, so I think just the guidance was to go with Emma's question. So that is it okay to take ibuprofen occasionally, or is there an alternative anti-inflammatory that we can take?
So ibuprofen, Voltarol, higher dose aspirin, they're a very specific group of medications called non-steroidal anti-inflammatory drugs, and they work in a way in which no other medications work. So it's a class effect for those tablets. They all work in the same way. Now, one of the things they do is they can interfere with kidney function, and they do that by several different mechanisms. And it's quite common, actually, for when people present with myeloma and bad kidney failure, that they've been taking non-steroidals. And some of you may remember that if you have had kidney problems, people get some pain with a myeloma, will take some Voltarol, or be prescribed some Voltarol indeed by a doctor. It'll help, and then the next thing you know, you've got your kidney functions down, and people have said, "Oh, it's the tablets." It's never the tablets in totality, but it will contribute. What I'd say about it is, I'm relatively relaxed about it in people who've got good kidney function. So if your kidney functions come back to a decent range, what's that? Well, probably an EGFR in excess of 45, and you've got myeloma that's in remission. Taking the occasional non-steroidal is probably not a problem. But I would try and avoid taking anything more than an occasional non-steroidal, and I would certainly avoid it if either your disease is active, such that you needed treatment, or if you've got kidney impairment, such as an EGFR of less than 45 ml per minute. So that, and then another group of tablets that's come up is lisinopril. So there's a group of tablets called ACE inhibitors, are also angiotensin receptor blockers, and they're used really commonly. They're first-line treatments for blood pressure problems, so lots of people are on those. They also protect the kidneys in some cases. Again, I mean, there's no problem with having those particular medications if your myeloma is in remission and if your light chain levels are okay. What they do is they will lower the threshold at which you develop CAS nephropathy if myeloma goes into remission and if the light chain levels climb. So what both ACE inhibitors do and non-steroidals do is that the level at which the light chains cause trouble is lower, on those medications. But I would take your doctor's advice on that. ACE inhibitors and angiotensin receptor blockers are very protective. They're not just for blood pressure, kidneys, but also they can protect the heart also in some people. So there's no contraindication to taking them. But if you get a relapse, then you should come off them. There are actually sick day rules for those medications anyway, that usually we tell people as kidney specialists, anybody who's on an ACE inhibitor or angiotensin receptor blocker, if you're unwell, if you vomit, if you've got a dose of the flu, just stop the medications while you've got that illness and then restart them when that illness is settled.
Perfect. We're running a little over schedule at the moment, so we probably have enough time for 2 more questions. So just ask a couple more of the pre-submitted questions. So one of the questions we've had is about CT scans, and can myeloma patients safely have CT scans and CT contrasts?
Yeah, that's a really important question. So it's not just with myeloma, but it's anybody with kidney impairment, low kidney function. Care needs to be taken with CT scans with contrast, because the contrast that's used. So when people have a CT scan, you can either have a CT scan with and without contrast. What contrast does, it allows blood vessels to be looked at. So you can see the blood supplying to things, and you can see, and it gives a lot more detail than without contrast. So that contrast can in itself cause kidney damage. And in fact, there are patients with myeloma who present by getting severe kidney failure. They're okay, but they've had a bit of bone pain. Somebody's investigated them. They may be taking some non-steroidal Votrol, and then they go and have a CT scan with contrast, and the kidneys stop, because the contrast on top of everything else has taken out the kidney function. The kidney function at which people start to get anxious about contrast is less than 30 ml per minute. More than that, the risks, as long as you're not in relapse with myeloma, is probably a low risk. The X-ray departments will have protocols for this, so they will know your kidney function in advance, and people should take an informed decision with you as to whether or not the benefits of having a CT with contrast outweigh the risks if you have significant renal impairment. An MRI with contrast does not produce the same risk to the kidneys, so it's definitely an option. There is a very rare disorder called nephrogenic systemic fibrosis, which people with kidney failure who get an MRI with contrast can get, but that's incredibly rare. And that would be an option. MRI actually, particularly for looking for bone involvement in myeloma, is actually a better test. That tends to be a better test than a CT scan anyway. So it's something to discuss with your specialists. And it's like, I'm talking to an informed group here. It's about taking an informed decision on an individual basis for the risks and benefits for yourself, together with your healthcare practitioner. But the lower the kidney function, the more the risk associated with contrast. Threshold of 30 ml per minute or less. You need to be more careful. If you're going to have contrast, then if you're on medications such as ACE inhibitors, rarely people will be on diuretics. You stop them before you have the contrast. You hydrate before you have the contrast. X-ray departments and specialist parts of the hospital have protocols for this, for making sure that you don't have contrast when you're dehydrated, because that really does put the risk up of having kidney damage.
That's perfect. We've just got time for one more question. And this one, so you've kind of talked a lot about the kind of having that close relationship with your clinician and talking to them and being really aware of your function and how treatment will be managed based on that function. But quite a lot of patients have asked, so Anthea and Susan have kind of asked a bit about, is there anything that they can do themselves to help protect the kidneys, or anything they should be doing to minimize their risk? So kind of lifestyle things they can do to. Yeah,
that's a great question. And this isn't specifically for myeloma. It's a general comment, really. I think the key thing about myeloma is this increased sensitivity of the kidneys to getting damaged. The smartest lifestyle thing you can probably do is avoid salt, okay? Because salt will predispose you to dehydration, and also predispose you to overhydration. It can put the blood pressure up, and it can sensitize to kidney damage. So things like, takeaways, fast foods, things you buy off the shelves and heat up in the microwave, mea culpa, the sort of stuff we all do. Just try and salt limit. My advice around fluid intake is don't get dry, but don't over obsess about it. Drink to thirst. A glass of water every couple of hours or so is fine. The more general advice in terms of protection, not just of your kidneys, but of your general health, is to look at dietary intake in view of carbohydrates, particularly fast carbohydrates and snacking, and brown foods. You know this anyway. Now, there's some interesting stories that wherever you look at a chronic disease, be it a heart disease or development of diabetes or kidney disease or strokes, that there's a risk in all those diseases from those sorts of lifestyle choices. But also those sorts of choices put you at more risk of having acute problems as well. So they lower the threshold at which you'll get an acute illness, and generally bring your resistance down. But I certainly think about your salt intake, and also maintain a reasonable fluid intake. When you drink, try and stick to clear fluids. Try and avoid sugar in drinks, for example. Just some simple rules around that. It's difficult, isn't it? Because the challenge for us all is we get into habituated behavior, and that we do these things on a day in, day out basis. The problem is that lifestyle change is one where you just have to take the habit and take the pain of changing the habit. And once you're a week or two into having made a decision around backing off on salt or cutting out the carbs, etc., it then becomes a lot easier. But it's that initial period of time is the most challenging one. But those generic advice in terms of lifestyle are certainly, if followed, are certainly protective for people with myeloma, but also outside of myeloma as well, because as the outcomes with myeloma are improving, you start to think more strongly about things like your vascular health and so forth in the longer term.
Excellent. Thank you for answering all those questions. That's all that we have time for today. Before we finish, I'd like to highlight some of the resources from Myeloma UK that you may find helpful. We have our Myeloma Infoline and Ask the Nurse email service. Our information specialists are available Monday to Friday, 9 AM to 5 PM, as well as the info packs and info sheets mentioned in the chat. We also have a range of publications that you can download from our website, or you can order a selection of hard copies from the order form on the website as well. All our Digital Infoday sessions are up on our website and on our YouTube channel that you can watch on demand. We have our discussion forum on the website where you can join conversations with other patients, family members and friends. Lastly, we have a range of support groups all over the UK. You can find details of those on our website too. I would now like to pass you back to Paul to take you through our take-home messages from the webinar today.
Thanks ever so much. Thanks ever so much, Caroline. Rather than read it, you can read the take-home messages, but probably the additional take-home message I give you is to check out with your healthcare professionals what's my baseline eGFR, and tell me about my light chain levels. And if you're going to, I'm a simple kidney doctor, but if you're going to write two things down that are going to protect your kidneys, or not necessarily protect your kidneys, but put you in a position where you feel comfortable. You know what it's like with any problem. You want to know that you've dealt with it, you've parked it, you know what it's about. Those are the two things that for you to have as baseline information. And then to hold the healthcare professionals accountable when you get unwell. If somebody tells you your kidney function's gone off, then say, Is this my myeloma, doctor? Could this be cas nephropathy? If it is, please can you get on with things as quickly as possible?
Excellent. Thanks, Paul. So you heard Paul talk, and today this talk covered what the kidneys do, how the kidneys can be affected in myeloma, and how myeloma kidney disease can be treated and managed. And that's us at the end. So thank you very much for joining us. Thanks to Professor Cockwell for speaking today and answering all of our questions. We hope everybody's found this information helpful and informative. If we didn't manage to answer your question or that it's inspired new questions, just get in touch with us. Again, you can do that through the info line or the Ask the Nurse email service. Details are on the screen now, so you can see them. The webinar will be up on our website and on Facebook soon, so do rewatch if there's anything you want to go back and listen to again. Thanks to our supporters, Myeloma UK is able to provide these free digital events like this one for patients and their families. If you would like to support the work of Myeloma UK, please visit the website and go to www.myeloma.org.uk/donate. Also keep an eye out on our website and on our social media channels for announcements of any future Digital Infoday sessions. And yeah, once again, I'd like to thank Paul for his presentation, and also thanks to everybody who joined in to listen to us today. So thanks and have a great night.